Good afternoon, and welcome to today's webinar entitled Virtual Care in the American Home. My name is Mark Haglund, and I'm Editor-in-Chief of Healthcare Innovation. Today's program is sponsored by Philips. Thank you so much to Philips and to our audience for giving us your time and attention today. Before we get started, I have a few housekeeping details to share with you. To submit a question, please use the Q&A box to the left of your video window at any time. You don't have to wait until the end of the program. For technical issues, please press F5 to refresh. And if that doesn't work, you can submit a question with your issue through the Q&A panel. Finally, join our webinar conversation on Twitter. You can tweet using the hashtag HILiveWebinar. Thank you. At this time, it's my pleasure to introduce our speakers for today's program, Cindy Gaines and Karsten Russell-Wood. Cindy Gaines, RN, MSN, is Chief Nursing Officer and Clinical Lead in Population Health at Philips. She has over 30 years of healthcare experience, splitting her time between quality and operations across the continuum. She was Chief Operating Officer and President of Administration for Health System in Kalamazoo, Michigan. And during her esteemed career, she has led the integration of patient care across the care continuum and integrated program requirements of third-party payers, including pay-for-performance criteria, to maximize clinical, operational, and financial initiatives. As Chief Nursing Officer and Clinical Lead for Population Health Management at Philips, Cindy serves as part of the senior leadership team responsible for developing comprehensive population health solutions. Karsten Russell-Wood, MBA, MPH, is a healthcare marketing professional with over 20 years of global product development and strategy experience. He currently serves as the global portfolio marketing leader for the Connected Care Cluster at Philips Healthcare. He's responsible for linking the innovations of Philips product teams to the prospect and customer-focused commercial operations of the business unit to build a Philips global brand, create consumer awareness, dominate thought leadership, and drive customer preference for the solutions through all channels. He received both undergraduate and graduate degrees from the Johns Hopkins University and holds an MPH from the University of Massachusetts. He is currently pursuing doctoral work at the LeBeau College of Business at Drexel University, where his thesis studies concentrate on value-based pricing and new marketing approaches in the healthcare solution market. Welcome, Cindy and Karsten. I'm going to turn the webinar over to you. For our audience, after Cindy and Karsten have completed their presentation, we're going to have what we call a fireside chat. So imagine a virtual fireside, and we'll have a nice discussion among the three of us. So please go ahead and take it away, Cindy and Karsten. Thank you.
Mark, thank you very, very much for that introduction, and congratulations to Healthcare Innovation for the viewership and listenership that makes you such a trusted source of information. As I address you and the audience, I want to say that as Philips, we're with you. We innovate together as teams to improve, extend, and even save people's lives. And for myself and the team, it's so important to remember that healthcare is personal. Our health and the health of those around us are a core part of our lives, whether we're healthy, consumers, patients, or caregivers. What we are sharing today are our insights and early vision of the North Star for a healthy home. And this brings together consideration for the environment we're experiencing today. Those on the front line working hard night and day, and the changes that could allow for healthcare to reach more people more easily. And a big part of this is the home. When we start looking at the home, and the reason this is entitled The New American Home, is when we think about classic images of what the American home is designed to look like. And we actually bring a reference from the Journal of Environmental Psychology that looks at the qualities that individuals look for in a home. And those are qualities of continuity, privacy, self-expression, personal identity, relationships, warmth, and safety. It's fair to say that with the environment that we've been exposed to, the home today has truly become the epicenter of life operations, and engagement by patients and consumers beyond the home is virtualized. We shop from our home, we communicate with loved ones and colleagues from home. We obviously work from home, worship from home, and educate our children, and also practice fitness at home. So it truly has changed in its role in our lives as individuals. And furthermore, the dynamics of the home have changed. Some statistics that I think are very interesting are the number of households continue to increase in the United States, reaching a level of about 128 million in 2019. And in these homes, we're starting to see a move to multi-generational homes, where children are living with parents and parents are living with their parents to have multi-generational abodes. As the aging population increases also, we see that not only do we have the expected baby boomer bolus, but we also have a hyper-aging or very old population of 85 plus, rising to more than 15% of the American population. And with all of that, we also have continued residents of about 20% of the U.S. population in designated rural areas, which are sometimes referred to as care deserts, because of the ability to access them with the right clinical supervision. Now, the forces that are changing the home are significant. But really, when we look at the home and we see the populations and the environment we're living in, what we also see is that individuals are starting to mandate that the home becomes a place not only for life operations, but also for healthcare operations. Dr. Eric Topol, more than 5 years ago, promoted the statement that the hospital of tomorrow will be in your home. And through that, we began to recognize opportunities for how the home and the forces of the home are making that a reality. What we've seen through COVID is payment reform and reimbursement extension through CMS has enabled organizations to positively accept telehealth as part of their care delivery program. We also see that the population in the homes are really mandating the safety and security, which allows them to receive care and remain healthy in the home versus proceeding to the hospital to receive care. The rising acuity of patients in our population also is supporting a construct where leading institutions across the United States are developing programs to offer care delivery and oversight of these higher acuity populations. Organizations that are truly luminary, such as Intermountain, Mayo, and Hopkins, have started hospital-to-home programs that move acute patients to the home environment sooner, improving operational efficiency, but also patient satisfaction. And now we're also seeing higher acuity practices of that, where ultimately the home, when outfitted with the right digital combination of solutions, communication, and collaboration, can serve as an environment, as a surrogate environment to the hospital. And this is principally needed for many reasons, but it's because we see so much of our population being afflicted by chronic conditions and diseases, and also the fact that the pandemic or the national epidemic of chronic disease can be a regional pandemic, because we see an unequal distribution of those that need help and the availability to receive it. I'm going to pass to Cindy now to move into the clinical domain. Cindy?
Absolutely. Thank you. One of the things I loved when I saw this slide and we created this slide is the question of, are we solving a disease problem or a systems problem? And I don't know, there's something about the world that we always want to say, is it the chicken or the egg? And what I love about this is that It's really both, and it's that perfect storm of it. With our aging population, it is the fastest growing, and we're living longer. So chronic conditions will go hand in hand with that. And these chronic conditions will drive healthcare spending. I don't need to talk about we all know there's a small percentage of patients at the top that spend most of the money. So yes, we do have a disease problem, but it's also a system problem of provider shortages that will continue to increase in the years to come, and access to care for these patients. And what telehealth and virtual care gives us, it gives the provider the ability to stay connected and intervene as needed. This increases their access to care, and it helps see patients through everything from a high-intensity time, such as the discharge from the hospital, which is when we most commonly think of it, so that we can potentially prevent a readmission. But it's also to think about mentoring that patient in self-management of managing their chronic condition and living well with their chronic condition in their home. We tend to be very reactive as an industry. So a hospitalization triggers an action, an ER visit triggers an action. What I think telehealth gives us, and working with the patient in their home, it gives us the ability to start to be proactive in the care of the patient. So, virtual care, it's nice to have. Is it a necessity? What I would say is COVID has changed everything for the telehealth business. For us, it's created an extraordinary need for what we have to offer and is being used in ways we never could have imagined. In a recent Frost and Sullivan's report, they noted that we're experiencing radical telehealth expansion, and we all feel it. The New York Times is now using words like the revolution to describe it. Telehealth has gone from being nice to have for chronic care to a necessity. So let's take a look just for a minute about what's going on in the industry before and now during COVID. Before, reimbursement was limited. Today, it's expanding. Medicare is already moving to create significant opportunities to generate new revenue. And just in the last couple of weeks, they've expanded more types of providers and platforms that are approved for use. Before, we had limited use clinically. And most notably, with patients with that high-risk population, we talked about the post-hospitalization patient. But today, everyone's a potential use case. There's an obvious need to keep patients out of the hospital, but it becomes more than about just the readmission to the hospital. I think the opportunity is how do we help patients to not get admitted in the first place? And we need to be able to remotely monitor patients, both contagious and not contagious. And we need to do it for all ages. So why are we hearing words like revolution? Well, again, we can see in the Frost and Sullivan numbers, the anticipated growth in this space is exponential. Remote patient monitoring is projected to grow 150% just this year alone. In a recent blog by Derek Ross and Michael Hoden, who's the CEO of the Global Coalition of Aging, they really captured the spirit of the moment and cited a British physician in the same New York Times article who said, it's been 10 years of change in 1 week. And I think we've all felt that. I was on a recent webinar in which one of the co-presenters shared that overnight they went from a small number of telehealth visits to just hundreds in 1 day. So it's going to be up to our connected care ecosystems to help bring together different populations and different needs of different platforms. We have to find ways to bridge this fragmentation and seize this extraordinary opportunity. So really what I want to share here is that beyond remote patient monitoring, Philips offers solutions that support the breadth of populations and programs across clinical and financial acuities. Again, it's starting to think of just how we can support the efforts, whether it's with the senior population and fall risk management and keeping them safe in their home, rising risk, which is really, it's again, trying to get against the reactive of the hospitalization and based on the patient utilization, who's starting to grow in the need to be better managed so that they're using the resources and the right level of care. Medication dispensing. medications have gotten complicated. Does the patient need dispensing support at home to remind them of their meds and to take it appropriately, whether that's an expensive med or just a really clinically needed med? And even COVID screening and symptom management. And again, I'm just going to say here, when we think about what COVID has done in this, is with the COVID-19, it's challenged us to think about virtual care differently, where we've typically thought about it in the past of the patient who's got a chronic condition, they've got a behavioral health condition that we're treating. You start to think about the wellness visit. You start to think about the healthy population. And who are those patients that potentially could be seen through at home, preventing them from coming into the hospital setting where they could have exposure. You know, I think one of the very recent conversation was talking with an organization about antepartum moms, and they were, you know, they're healthy. We see them every week in their last trimester, but they're coming in for blood pressure checks and to have their weight done. Maybe we could do that remotely with a virtual visit and remote devices, and having them come in for just very critical visits around a stress test. So again, thinking about this world differently is that new American home of it really becomes an extension of the care setting and another place of care for the provider. So what else is new that's going on out there, Karsten?
Thanks, Cindy. Really, I think, you know, what we're marking here is a combination of a burning platform, right? A change in environment and opportunity to respond, and clearly this is an opportunity to respond from many different dimensions. And if we look and we compare and contrast the infrastructure that we've come to appreciate in the hospital domain, we can also then extend that to identify or overlay what infrastructure tools would benefit equal care in the home setting. And we see that through simple design construct of ensuring that evidence-based care planning can be done, that care teams can communicate and collaborate, and that, of course, access and the tyranny of distance is mitigated through the use of solutions such as telehealth, as Cindy mentioned. And lastly, of course, data interoperability. How do we support the information systems that have created the backbone of our acute care system for beyond the hospital? As we're connecting care anywhere in the marketplaces, there's new evidence of innovation that's come through crisis, but also aligned with the crisis to improve outcomes. Some examples are, of course, this promulgation and prominence of healthware in the home, solutions that can be, you know, integrated into a chronic disease care management program or into an at-risk, admission reduction or mitigation program that support the convenience and comfort for patients and consumers to be worn in the home. And this digitally transmits the information through to 24/7 dedicated care teams that are leveraging computer surveillance, but also algorithms that allow a single clinician to monitor populations of patients that hasn't been recognized before. And we also realize that, you know, the home isn't the only place the care can be delivered. So bringing care to communities, whether they're urban, rural, if they're connected to retail organizations, so that an individual can not only shop but also, you know, get their healthcare checkups that they urgently need for themselves, for their children, and their family, really is an opportunity to create a safe space, a space where any type of specialist, any form of physiologic monitoring solution and collection and observation can be done. And that then, of course, integrates into the patient chart. And lastly, the phenomenon of mobile monitoring. You know, so much of our world has to be connected, and bringing the same level of Amazonification and consumerization of monitoring to healthcare will allow us to connect those pockets of care to truly make a hospital-to-home environment. So I'm going to stop there. Cindy, anything from the perspective of that slide you'd like to comment on, or Mark, we may pause and see, what questions you may have for us.
Well, I'm ready, but Cindy, did you want to respond to what Carson just asked?
No, I think Carson did that great. So I think let's start our fireside chat. Let's throw a log on and have a conversation.
That's right. The audience can imagine us virtually throwing a virtual log onto our virtual fire. So anyway, what I am so interested, and I'd love to hear from both of you. Perhaps, Carson, you could go first, but I loved what you said about the home, how it's becoming an epicenter now for, out of necessity, work, education, socialization. Given the situation, and you also mentioned, which I thought was very important, we're going back to multi-generational households again, which 100 years ago were the norm. What are the implications of that for healthcare? I mean, I think it's fascinating because many of us still in our minds think of perhaps nuclear families, perhaps singles, perhaps, people who are roommates who are not in relationships but share a household. Now, the way that we're arranging our lives is becoming much more truly connected. We're working out of our homes. Many are mostly staying home to socialize. What are the implications of that for healthcare delivery, Carson? And then, of course, Cindy, too.
Yeah, Mark, the home is such a profoundly personal place, right? And when we said, this new American home, the imagery is Norman Rockwell, right? These iconic paintings of what a home should look like. And, today that home can be anything, right? It could be a single, room apartment in New York City, or it could be an expansive estate in the middle of a, rural countryside. But the home still has changed, as you've pointed out. And for health systems that need to continue to deliver care to their patients and their beneficiaries, it's about reach, right? Reaching patients in the home, and how do you do that better? And what needs to be available from a systems and a monitoring and care team perspective to support it? Well, the first thing is, we're trying to mitigate the trade-offs in precision and accuracy that have always limited the ability for higher acuity patients to be cared for outside of the hospital walls. And secondly, it's also a behavioral construct where we now also encounter patients that for at-risk, for safety or risk concerns, would prefer not to receive care in the hospital. There were some significant studies published, that showed out of the Northern Kaiser region, Northern California Kaiser region, that the rate of MI was reduced about 50% during COVID. Well, that wasn't because people were healthier. It's because they elected not to receive treatment, and that's a profound view of how they viewed the ability to receive care and the ability to be better off. So I think person and family dynamics are certainly shifting. I do believe, as I said, that Amazonification of healthcare has arrived, where depending on, what state of care needs we are in, we are more empowered as consumers to elect to purchase some of it ourselves and manage that within an ecosystem that we believe will transmit that information and communicate it for a single patient record.
I have a thought, but Cindy, would you like to add on to that first?
I would. And, I'm going to approach it just a little bit differently. And that I think when we think about the epicenter, the American home being the epicenter, it changes how we talk and function as healthcare organizations. I've been a nurse for over 30 years, and we talk in terms of a discharge from the hospital. And it's almost like we need to eliminate that as a word, and it becomes just another transition of care. And we're used to that transition. When I worked in critical care, we would transfer to the floor when the patient was well enough they could go to the floor. And then when they were ready to go home, we discharged them from home. And when you discharge, there was a time when it's okay, next, and who's the next patient I have to take care of? And what we're really talking about is that this is transitioning to another level of care, and that is the home. And there's trust issues with that. You know, when the critical care team is, will the family, will the floor do as good a job as we need them to do? There's always that trust that comes with building that relationship between those areas and trusting the transition of that patient. And in many ways, we have to build that trust with our patients, that as we transition them to home, as opposed to discharging them from the hospital or transitioning to the next level of care, is we're going to have to partner with them in a different way because we're staying connected. And it's just a very different way of looking at the world and building that trusting relationship of helping them to learn how to manage monitor their own vital signs and how to, when to connect. And it is a partnership that changes the dynamic.
I think that's great, Cindy. And I think you're right. I mean, the whole idea of discharge will become almost antiquated in a way in terms of, I totally agree with, like what's a discharge? First of all, technology will allow more and more care to be delivered in the home to begin with. So most people, many people will never leave the home. If I may, Cindy and Kirsten, I'd like to share a brief story, if you don't mind. About 8 years ago, I happened to be in New Mexico and traveling, and so I planned a visit to Presbyterian Health Services, which is one of the leading hospital systems in Albuquerque. And they gave me a wonderful opportunity. They were one of the first integrated health systems to create a hospital at home program. And I went out with an advanced practice nurse, and they use both physicians and advanced practice nurses to do house calls. And I went with an advanced practice nurse to do a house call on an elderly gentleman. I don't even remember his name, but I'll just call him Mr. Smith. So Mr. Smith lived with his adult daughter, who was in her 40s, and her children in a home quite far out. Albuquerque is very spread out. It took us about 35, 40 minutes just to get there by car. He was in stage 4 COPD, stage 4 lung cancer with COPD. And in fact, they were just informing them that he needed to be transitioned to hospice. But in any case, it was fascinating to see their situation because here, his adult daughter, as I say, I think she was about maybe 43 to 45. She had 3 children of her own to take care of. And she was taking care of her father, who could, because of his very advanced stage of lung cancer and COPD, he really could only walk about 8 to 10 steps at a time. That was literally his circumference of mobility. And as this advanced nurse practitioner told me, to bring him into the hospital in downtown Albuquerque, unless it was something where it was an all systems failure, was really bad. Total disruption for him, for, like a checkup. Can you imagine, that long drive, and, he was constantly connected to oxygen and things like that. So the whole point of that story is, I think, when we think about the family and we think about how society is evolving and about chronic illness and care management, what the situation with Mr. Smith is going to be repeated countless times in this country. Would you agree?
I would agree with that completely. And think about that. And what's wonderful about that story is that they understood to take the care to them. When I was president of our medical group, I can't tell you how it was almost painful sometimes to watch the patients coming in from the parking lot, because it was like, watching someone get off a ship with all their possessions. And it was 45 minutes just to walk from the car to the parking to the building. And we got to take the care to them, because that's where they're getting their care, is in their home. And so how do we help them to do that better?
exactly. And the adult daughter of Mr. Smith told me, if we ever do go into the hospital, it's really, really hard on my dad. It's like it makes him.
Oh, yeah.
So it's like your story of taking 45 minutes to go through the parking lot. So speaking of that, we've been talking about virtual care. Now, tell me, if you would, Cindy, begin, where is telehealth headed? What are the challenges and opportunities involved in making virtual care via telehealth, virtual care delivery a reality? And what have we learned? Because I know a lot of provider leaders say, wow, before COVID, we were doing it in very small doses, but to bring it up to scale is a completely different animal. What are your thoughts on that?
Yeah, I think the thing we've learned is we can do it. And there's been a lot of hesitation to jump in. If we look at pre-COVID, it was about 15 to 20% of American health systems had some form of telehealth. And during COVID, 75% of them had some form. And that's called, it's learning to swim by being thrown into the deep end. We had to do it to take care of our patients and have business continuity. So what we learned is we can do it. I think the challenge is going to be how to create this from a longevity perspective and the scaling that you talked about. The three big challenges I see is they kind of fall into reimbursement, licensure, and interoperability. So if we talk about reimbursement, it's really difficult to advance a strategy with one chief financial officer if you're not getting paid for it. So, Medicare has done significant improvements. They're continuing to try to they're making improvements, and which is advancing this. The parity laws that have been developed from state to state have helped again with that. So we're seeing a lot of movement, but it's a great start, but it continues to have its challenges. We have to make this as easy as possible from a reimbursement perspective. It needs to be recognized by all as and paid as a regular office visit. And the challenge that in making so in states. So again with that, then the other one I meant, sorry, I got a little lost there. Licensure. We continue to have challenges with licensing, and that for a provider to see patients that live in another state, and where is the provider licensed, and where does the patient live, and that's an issue for both providers and nurses. Nurses, again, we're making some advances with that, but with the shortage of these providers across our country, we need to be able to take advantage of clinicians where they live and where they're licensed, regardless of where patients live. It's improving, but in a virtual world, this has to become a non-issue, so that we're able to use our resources as best we can across our country. And then the last challenge I would say here is interoperability. Is we tend to focus on what's easy for the patient to use. And I think the greater challenge in our technology world is our providers have had their workflows and their patient care has become very complicated to maneuver with all the, from an IT perspective, multiple EMRs, vendor technologies, apps, logins. In many ways, our EMR and healthcare technologies have come between the patient and the provider, and yet that's still the most important relationship. One of the most common complaints I would get from patients and providers was about this. So how do we support the provider and making it easy? And that's going to take an ecosystem approach where we're not working in silos, but we're connecting our solutions so the provider can use that and the patients can benefit.
I think that absolutely. I think that's so important. Karsten, would you like to comment on that? And then also, if you can comment a little bit as well on the whole reimbursement and regulatory landscape, which I would love to talk with both of you about. But first, what Cindy just said, and then go big on the landscape.
Yeah, I think in what we're starting to see, Mark, are studies and research that shows there's a decrease in telehealth interactions in the past couple weeks. And I think what we need, I think Cindy, you said it so well, we have to support the evolution of the standard of care, if that standard of care is in the hospital or it's in the home. And telehealth, it really is an enabler to advance the standard of care. It by itself is not, a separate solution in itself, right? So, if, to Cindy's example or yours, the world of a PCP and their engagement to manage a chronic disease patient could be improved if that patient's trip to the, office could be supplemented by a virtual visit. We've improved care, right? We've improved the standard of care. So I think first and foremost, it's important that telehealth by itself is really an enabler. It's something to improve how we or our providers or systems are able to deliver care. I think the second point when we see and we look at that drop-off that's occurred, I think it's also important to realize that, even as CMS's SEMA Pharma has projected, telehealth and the reimbursement that encouraged the use of telehealth through COVID and continuing is terrific, right? Because we're trying to achieve parity in reimbursement. But that doesn't mean that we're trying to see telehealth as the replacement for the office visit entirely, right? There's clearly a place for the patient-provider relationship, one that includes and is built on empathy and observation and trust. But telehealth can increase the efficiency of those visits. So by seeing a drop-off in interactions with telehealth, we also could be seeing that is being traded off with the opening up of offices again and elective surgeries where patients are able to continue that relationship. So I think that's very important.
Yeah, I think that's
Go
very
ahead.
important. I think, and I'll ask, Carsten, I'll ask both you and Cindy to respond to this. I had an interview that was very interesting recently with an orthopedic surgeon who is one of the medical directors of an orthopedics group in the Southeast. And he was talking about what a patient visit is like now. Some of the time, they're able to do it through telehealth. There are times when it's absolutely vital for the patient to come in, and then they bring the patients in. But most of the time, even orthopedists are able to do it through telehealth. So I think one of the things that's happening is the whole idea of what a doctor-patient visit is starting to evolve a little bit. Cindy, do you have any thoughts on that in particular? Because I think this is where I'm fascinated by how the clinical, the operational, and the financial all are kind of shifting at the same time, right? Like just as with COVID, everything, all the operations inside the hospital have had to change to adapt to the current situation. When you get to remote care, it's changing how clinicians are thinking about what they do also. Do you have any thoughts on that, Cindy?
Absolutely. I think, again, if you think about from the patient perspective and even from the providers, one of the frustrations for patients is as we have, as hospitals are covering larger and larger geographic areas and patients are driving farther to get, they may see the primary care in their small town, but they're going to go to usually a tertiary care area to see a specialist. And so as you're driving those distances, there's a big frustration, and I'll just use the example, and many people have had it, of you've had surgery and you go for that post-surgical appointment, and it lasts like 5 minutes. It's like, can I see your incision and how's your pain? And, let us know if you have this happen. Do you have any fever? And it's frustrating for the patient who's driven a long way for that, but they feel like they have to have that. And I think what we're seeing with telehealth is, again, when's the right time for the physician to see the patient? When can an advanced practice provider see the patient? But what are those times that we could take advantage of being more efficient by, and I've seen organizations do that. What conditions could be seen using a video visit where you could hold up and let me see your incision, and I can ask you these questions about, have you had a fever? How's your pain? And you know what? It makes the provider more efficient in their day. The patient likes that, and they didn't have to travel a long distance. And often when you look at those surgical procedures, that's really easy because that first visit is part of the global visit from a finance perspective. It's included in the surgical DRG. So,
Right.
you know, it's one of those things to pick off early because you don't even have to worry about how you bill for that and get reimbursed. You're getting reimbursed. How do you make it easier to do? And your providers, they actually like it because it's more efficient. Now, could you do that for everybody? No, but there's a lot of patients you can, but it kind of starts to break the rules of how we've always done it. And some of that's our own comfort level because what will happen, and this is, again, I would say what we had was the opportunity to jump in and start doing some of this. And this is the world, I think it's being more creative as opposed to just a chronic condition. And again, so what we were on a call the other day, where even sometimes it's just a telephonic visit because if you have a bladder infection, seeing you on the camera is not going to tell me much. A lot of it's interviewing, so it's getting comfortable with those interview skills over the phone and virtually with the patient.
Well, in fact, Cindy, the orthopedist I spoke to, who I interviewed, said exactly what you said. He said, we've gotten more efficient and more effective. We just had to kind of rethink how we did the typical patient visit. Some things can be done, certain things can only be done by the physician, but many things can be done by the nurse practitioner, the PA. There are many ways to slice the lemon. I used to say skin the cat, but that offended too many people. Many ways to slice the lemon. And so I think one of the things that's so fascinating is how those elements are morphing. Now, Karsten, what do you think? There's a question has emerged. Will CMS continue the relaxation that started this spring in terms of the regulations around licensure, et cetera? Because many people, and payment parity, because many provider leaders are saying if payment parity and licensure regulatory relaxation do not continue, it'll be too hard for them. If we go back to a situation in which telehealth delivered care is goes back to being only reimbursed at a low level, that would be too difficult financially. What are you hearing?
Well, I'll tell you what has been an excellent kind of surprise through the administration with Seema Varma is a progressive approach to solving a problem, and solving it in means that are different from just access alone. So what CMS has done, but also we see this not only at the national level, we see this at the state level with Medicaid and different state-based endorsements for reimbursement. We see that it's supporting and it's driving efficiency and value. And if we look at how CMS as an organization is addressing care transformation, I would expect that many of the benefits that they're recognizing and auditing will result in more sustainable change. Organizations such as the American Telemedicine Association under CEO Edmond Johnson are advocating to tell the stories of patients, tell the stories of providers that personalize how telehealth has resulted in better care delivery. And I believe that that's our position too, is to prove and demonstrate the efficacy of telehealth as compared to what existed before. And I think we're seeing that. I think what we're also seeing is telehealth is not just the consult, right? There's a lot more behind the camera than simply the interaction. So, for example, to Cindy's point, we're using solutions that are linked together through interoperability. We're using, wearable sensors, or the market is now seeing wearable sensors that transmit continuously data to teams that can analyze and review it. So we're moving progressively from purely treatment to diagnostics to prediction. And certainly I believe if we can deliver health care more efficiently, I would expect that the would certainly advocate for that.
Wonderful. Thank you for that analysis. Well, it turns out in the last few minutes we've gotten a landslide of questions from the audience. So I'm going to shift us to responding to audience questions. I'll throw each question out to both of you, whoever would like to respond. Our first question is, can centers similar to tele-ICU be set up for critical care / chronic patients at home, similar to those in hospitals? Is there enough clinical need case, or is it too futuristic for health providers right now? Good question. Cindy, do you want to start, and then Karsten, if you have
Sure. Sure. I don't think it's too futuristic. I think we're already starting there. Meaning that if when we look at our the ventilator population, there's a lot of patients when we look at our respiratory part of our company that are supporting ventilator patients in the home. When I was working in critical care, we would never have sent a ventilator patient at home. That was critical care. And we didn't send them to the floors. And now we have patients we're caring for in their home, and they're being remotely monitored. So in some ways it's happening now. And that, I think, is just groundwork that we'll continue to build upon. Again, as we start to, I think people think of telehealth and they just think of the visit. And I'll go back to what Karsten was saying. It's so much more than that. And it's really about virtual care and what are the patients we could help care for virtually. And in some ways, we've already started going on that path. And I think we're going to see a lot of advances in that in the next few years.
I think that's wonderful. If I may, there's a question that I'd love to pitch to you first, Karsten, if I may. Go ahead. The audience member asks, there are elderly individuals who are choosing to age at home. With circumstances like COVID, this may cause social isolation and influence physical and psychosocial well-being. Do you think there is a space and a need for health systems to not only deliver healthcare via telehealth, but opportunities to connect virtually for physical activity and nutrition? In other words, wellness they're asking about. I think that's interesting. Karsten, why don't you go ahead, if you would.
Yeah, if we look at tele as a prefix, the suffix, I think, is now being unbounded. We can apply it to nearly any care venue and any exercise. There's profound leaps in innovation in tele-rehab, for example, which are just remarkable. But you also touched on isolation, and when we talk about the home and the qualities of the home, there are also the aspects of the home that can be concerning, such as for populations that are living alone, aging in place, but now isolated. And certainly we've seen that telehealth can deliver supportive mental health solutions to truly benefit those individuals. But it's also, in my mind, a very circular path, Mark, between, the technology, but also the humanistic side. And certainly consumer solutions for engagement, as we've all seen with Zoom and other solutions, has certainly tried to reduce the distance and the divide between households. And I think that'll certainly improve. But to your point, if I'm an institution that is trying to reach my consumer base into the home, I'm really going to not only do it through the clinical lens, I'm going to do it also through the social lens. And, great examples of that do surface where organizations through their web portals or consumer web portals have integrated in musical medication tools, calming tools, and other forms of mental well-being and cognitive well-being. So certainly agree with that. And lastly, I think from the provider standpoint and the institutional executive standpoint, I believe telehealth truly has supported this lens of clinical curiosity, right? How can I re-architect a care plan if I put the ingredient of telehealth into the recipe? It's a brand new paradigm, and I really think it's ripe for exploration.
I think that makes tremendous sense. So we have a good problem, panelists. We have 7 more questions in about 7 minutes. So what we're going to do...
Are they yes, no, Mark?
Well, no, they're not. That's the hard part, right? So I think what we're going to do, if you'll indulge me, I'm going to do this in a kind of a lightning round mode, if I may. I'm just going to ask one of you to answer this question.
I feel like it's a competition. Okay, I'm ready. Let's go.
Right. Yeah, it's like
family squares.
On the buzzer, yes, exactly. So I'm just going to toss each one to one of you, just in order that we can accommodate our whole audience. So one of the audience members says, can you speak to a public healthcare model, part of healthcare, continued care, disease management, population health management, and the technology required to support population health management? I think I'll toss that to you, Cindy, if you would.
Oh, thank you. Can I speak to a public health care model? You know, what I would say to that is, you know, public health has been an important part of the healthcare systems for so long, and in some ways have been treated kind of like outside of the health system. So there's public health, and then there's a health system. And what I see is it's marrying these two worlds together, because we can learn so much from our public health experts, and how do we incorporate what we can learn from them into having the home be an extension of our care center. And it's bringing those two worlds together. So what I see is this is an opportunity for us, again, breaking down the silos of, oh, I have this great expert at the health department, I have this great public health expert at the university. It's time to stop being there and bringing them all together and saying, let's talk about how to make this better. So it's really barrier busting.
Great. Thank you so much. I'm going to toss the next one to Karsten. Do you see this as a one-solution-fits-all approach, or different scenarios and products for patients with different conditions? And if different, then how?
Oh, terrific. I get the layup. Thanks, Cindy. So very, very simply put, when we examine, let's just take, for example, chronic disease patients, which, account for about 133 million of the American population. You can Pareto those conditions and find that there's a significant portion or percentage that require the same care management. But there's some that are obviously very I don't think it's one size fits all at all, because at the end of the day, merely bringing in telehealth doesn't mean that it's going to scale and be sustainable. And I think what we have to look back on in the implementation of telehealth programs over the past 2 decades, Mark, is that some succeed in limited populations, but many fail at scale. So ensuring that you have a very robust blueprint for how you will bring telehealth together at a systems and an organizational level is critical.
I completely agree. Wonderful. Thank you. Cindy, are you ready?
I'm ready. Go, Mark.
Okay. Yeah, I know. It is like lightning round. What are some of the limitations for why healthcare organizations, in parens, hospitals, and physician practices, have not fully adopted telehealth practices beyond reimbursement of services by CMS or the health insurance industry? I think what they're basically asking is why provider organizations haven't been self-starters, as they call it, in this area until now?
I think up till now, the reimbursement was a big one. I mean, it's complicated in how I bill if you're CMS versus a commercial payer, and when it gets complicated, you're less likely to do it. But I think, and we've talked about the limitations earlier, and I won't go over those again with licensures and technology. But I would throw in here, I think a big limitation of why people haven't jumped in has been a lot of misconceptions and fear of jumping into it. That, people believe, the aging patients can't do technology, or the provider they won't like the non-touch visits, and even discomfort from a provider of giving up hands-on and interacting with the computer is so much different. And all it takes is one time for the computer to not work right when the provider tries it, and then they're like, well, I don't want to try that again. It didn't work, So I think it's what we saw with COVID is you just had to jump in and do it. And what we got past was a lot of those fears, but the other real challenges continue to be there, but I think they'll improve over time.
That makes sense. We have about 3 minutes and 2 more questions, and they're big questions, but I apologize for that. Maybe I'll throw this one to Karsten. How will homeless care be provided virtually? Presumably meaning care for those who are homeless. Centers of care for indigent/food/poor/living on the streets. We could do a whole webinar on that, but do you just have a thought on maybe the landscape around helping those who are either homeless or semi-homeless, Karsten?
Actually, I think there's some really interesting organizations doing phenomenal work, and we also see that there's some states through, some of the disparity in race and in income that have, been obviously, brought to light. States have done a lot to focus on healthcare reparations, which I think is such a tremendously profound opportunity to improve equitable access. It comes down, I think, also to being able to simply bring care to where individuals are. And the more efficient health care is delivered, in total, then distribution of funds to support not only indigenous but also lower income areas is possible. Now, as I said in the beginning, what can be a national epidemic can be a regional pandemic, right? Chronic disease is not equally distributed across the United States. And so opportunities for states through Medicaid, through telehealth, to deliver special programs and deliver funds to support them certainly is something that we're starting to see quite a bit of.
Great.
And I want to jump in on this one, Mark. I know you didn't ask me it, but we get really excited because we're doing a virtual care booth, a pod, and we're doing it with our VA partners to provide care to remote locations. But that same technology is something that could be in a gospel mission, it's a booth where you go in and everything's there, and it's just connecting them to a provider. So there's ways that we can start to think about telehealth, and as Karsten said, it's about connecting and getting the care where it needs to be. Oftentimes it's just starting to having that virtual connection, and there's ways to do that in using this booth technology. So there's really, I think, some exciting opportunities ahead of us.
Wonderful. Well, we have 1 minute left, but I'm going to extend this a minute. I'm going to ask each of you just to leave us with one good piece of advice for our audience. It can be on anything that we've talked about, but one thing that you'd like to leave is kind of like an elevator speech piece of advice. Karsten, do you want to go first?
What I would say is necessity is the mother of invention, and we're in that world today. So I think just connecting telehealth and the new innovations that are being created all around us can improve care access for everybody.
Perfect. Cindy?
Well, mine would be to, don't be afraid to innovate, and don't be afraid to fail. fail often and fail early and move on and try and tweak it. Gone are the days of piloting and piloting. We used to pilot for 6 months, 12 months, 2 years. Pilot it for 2 weeks and then tweak. Pilot it for 2 weeks and tweak. This is about innovating and just failing early and failing often. And failure it's a success because you learn from it. And it's not, you may walk away from something, but it's okay to fail.
I think that's absolutely wonderful. And I'll just say that absolutely validates and affirms what leaders of patient care organizations are telling us in our reporting. Fail early and often, and then you get to success. So, Karsten and Cindy, thank you so much. This has been absolutely fabulous. So I'm going to conclude now. Unfortunately, that is all the time we have for today, but I want to thank Cindy and Karsten once again for today's excellent webinar. And I'd also very much like to thank our sponsor, Philips, for making today's program possible. Finally, thank you to everyone in our audience for joining us. We hope you'll join us again in the future for another Healthcare Innovation webinar. This concludes today's presentation. Thank you all very much and have a wonderful day.